Good morning, everybody. Let me thank Dr. Kamaluddin and the committee for asking me to be here to talk about this topic. And as Simon already told you, sorry for the attire that I'm in. I've literally been hijacked from the airport straight here. So what I'm going to talk today is something that is very, very important in our region. So let me start with greetings from my country, India. So this is about how I tailor my treatment based on the resources that we have. So the outline is going to be about the introduction, a little bit about knowing your enemy, evidence-based medicine, and the management in low and middle income countries with some examples. I'll be talking about non-small cell lung cancer, breast cancer, head and neck, and also supportive care, and show you some evidence of each one of these examples that as a group we have done across the country. So this is to quote from Sun Tzu, who said that if you know the enemy and know yourself, you need not fear the results of 100 battles. And therefore, we need to know our enemy first. And our enemy today is the cancer disease. So a little bit about what we are looking at. This is looking at 8 risk factors which account for about 50% of deaths from cancer. And as you can see, tobacco use is the leading cause for it. And as you can see here, high income, middle income, and low income, in fact, all over it is important. But in the low and middle income countries, this is one of the most common causes of cancer. Others following are the H. pylori, alcohol use, hepatitis B and C, low fruit and vegetable intake, human papillomavirus, physical inactivity, overweight, and obesity. So if you look at this map, this is the geographical world. But if you really see what it means in terms of population, the whole map looks so different. And I must actually thank Dr. Purvish for letting me use the slide. So when we look at these problems, we need to see how we can give the best to our patient. So it's in the best interest of our patient for us to adopt EBM. So what is EBM? So we all know EBM means evidence-based medicine, but it also can mean eminence-based medicine for some and economy-based medicine. That is what we're going to talk about today. So an important rule in evidence-based medicine is that it starts with the patient and ends with the patient. The patient's preferences must always be considered, and this is today being talked about as participatory medicine. So in the practice of EBM, it's physician's duty to find the best and most current information and apply it judiciously to the benefit of our patients. But a practice based exclusively on science and math is effective only if your patients are robots or clones. But that is not the case when we treat our patients. So we need to look at the individual human differences and the personal preferences. So 3 major components of EBM is the patient, the physician, and the information that is there. And using all this, you have a question or a problem and you answer that. So for the patient, it has the values, the concerns, preferences, expectations, and life predicament. And also what comes in is the economy that is there. So we are talking about personalized cancer care because we have learned so much about our enemy, the cancer, and also the advances that have happened in various fields, some of which Dr. Purvish already showed you. And therefore, the concept that one size fits all treatment is gone. And in the era of medicine, it does not exist anymore. So this is personalized cancer care. But today I'm going to talk about this. This is personalized cancer care. So for this, I'm going to give you some examples. So let's start with non-small cell lung cancer because this is one of the most common cancers in this part of the world. And for this, we actually published this paper looking at pharmacoeconomic benefit of cisplatin and etoposide chemo regime for metastatic non-small cell lung cancer. So when this study was done, the 2 new drugs that we had was pemetrexed and gemcitabine. So we decided to compare these 2 with paclitaxel and etoposide, which have been used for quite some time. And why this was important was because of the costs. So when these drugs came in, the regime of etoposide platinum costed 1,500 rupees, paclitaxel platinum costed 5,500 rupees, gemcitabine paclitaxel costed 80,000 rupees, and pemetrexed costed 1,50,000 rupees. And remember that it was at this time when we did not have generic drugs and therefore the cost was very high. So we thought whether we could use the simpler drugs that are available and much more economical. And this is to show you the survival curves that considering the cost and the efficacy, etoposide and platinum was doing just as well as pemetrexed and platinum. So that was an important issue because cost was an important part at that time. Of course, today we have a lot of generics of gemcitabine and pemetrexed, but still etoposide and platinum is relatively cheap. So this was the other study which Dr. Parikh led, which looked at, again, at that point of time, as I mentioned, gemcitabine was expensive. Therefore, we looked at low dose prolonged infusion. So the concept is that the phosphorylation of gemcitabine is catalyzed by deoxycytidine kinase, and the enzyme gets saturated at infusion of 30 minutes. So enhanced antineoplastic activity is only by prolonging the infusion. Therefore, what came out of this study was we used a dose of 350 milligrams per meter square, that is 33% of the recommended dose, but the infusion was over 4 hours. This was a study done in 30 patients, and we showed that the response was 66% as reported with the recommended dose across the world at a reduction of 66% of the cost. So this is something that we were able to show that we could definitely decrease the cost of the therapy. So this is just showing you that how we have progressed in improving outcomes of metastatic non-small cell lung cancer. In the 1970s, all we had was best supportive care, then came in platinum, and then we started looking at clinical selection based on histology, and that improved the outcomes even further. And then as we have come further, as we have understood what this disease is, by which I mean how we know our enemy, the outcomes are in the excess of 5 years today, which was unthinkable a few years ago. So this is just to talk about one of the important problems that we have in adenocarcinoma in this part of the region with the EGFR mutations that are there, and the drugs that we have is tyrosine kinase inhibitors. And this is just to show you the evolution of EGFR mutation positive advanced non-small cell lung cancer. We started with gefitinib and erlotinib, and today we are having the third generation tyrosine kinase inhibitors, not just for their use in metastatic, even in adjuvant setting. But again, this is an expensive drug. So I will quote this paper from Tata Memorial Hospital, which looked at using gefitinib plus gefitinib with chemotherapy. And what came out of this was that the combination of gefitinib plus chemotherapy definitely increased the outcomes, improved the outcomes, and at a cost that was much, much lesser than the third generation tyrosine kinase inhibitor. So this is the other molecule that has been made in India, which is nimetuzumab, which is an EGFR monoclonal antibody. And this is a study that we did across India several years ago. And what we did was combining this with chemotherapy. The drug that we used was docetaxel, and we showed that the response of the arm that used nimetuzumab with docetaxel was 60% as compared to about 39% with chemotherapy alone. And this again was an effective way of using this drug in our community. We even have published this paper in 1994. This was the other study that we did looking at the evaluation and safety and efficacy of minocycline combined with tyrosine kinase inhibitors in patients with EGFR mutated metastatic lung cancer. This was a pilot study that we did. And the concept for this came about because minocycline has been recommended for the treatment of tyrosine kinase induced skin rash. And analysis of that data, they showed that there was improved survival in these patients who use minocycline. And the concept was that minocycline inhibits PARP and EGFR mutant tumors are deficient in BRCA, leading to the synthetic lethality that we always talk about when we use PARP inhibitors. And so looking at this, we did this study, and this was presented at ESMO 2019, we showed that the median PFS for the Geftinib arm was 9 months, whereas for the arm that got minocycline, the median survival was not yet reached. So this actually showed that, in fact, this can be duplicated. We can use minocycline as a very cheap PARP inhibitor, and therefore we are now putting up a study which has just been approved by our ethics committee to look at the BRCA-ness in various solid tumors, because if we show that this is in fact possible, that there is a high BRCA-ness in many solid tumors, we could exploit this as a target for therapy. And again, we could use minocycline as well, as we have shown in this pilot study in non-small cell lung cancer. With that, let me go on to the head and neck cancers, which again is a very important problem in this part of the world. And this is showing you that an EGFR blocker along with chemotherapy and radiotherapy improved outcomes. This is a meta-analysis, and which showed that this concept in fact is true. But there is a lot of toxicity of cetuximab or panitumumab in terms of the rash and the electrolyte disturbances that are there. So this question was put forth, do we have a better anti-EGFR monoclonal antibody? And we did have that. This was nimetuzumab. Again, if you remember, I showed you we used this in lung cancer. We did one of the first studies for this molecule in India, and we have actually published the 5-year survival data for this, showing that the outcomes with the use of nimetuzumab with chemoradiotherapy is far superior to those who did not get it. And the important thing that I have put up here is the very minimal amount of rash which we saw in about 2 to 3 patients, which was just about grade 1 in them. And this is the paper that we have published with a 5-year follow-up. So with this, there is a lot of shift in the way we look at treating locally advanced head and neck cancers. We generally categorize as whether they are fit for a surgical treatment or not fit for surgical treatment. And then we have actually tried to use neoadjuvant chemotherapy, and the newest one is the use of neoadjuvant immunotherapy. And this initial data has shown that the pathological complete responses are dramatically improved, almost to 48% when we give about 2 doses of neoadjuvant immunotherapy before surgery or before definitive radiochemotherapy. So immunotherapy is again very, very expensive, and we have some data from India again to look at use of low dose immunotherapy in recurrent metastatic head and neck cancers. And based on this, we are now proposing a study at our center looking at low dose immunotherapy in this neoadjuvant setting. So this is a study that is planned, which has again been recently approved by our ethics committee. We are looking at the use of low dose immunotherapy with chemotherapy as a neoadjuvant regime in oral cancers. So with that, let me go on to the breast cancer. This is just to tell you how important our understanding has been in the role of hormones affecting breast cancer. And this is again to just show you the development of endocrine therapy, starting with the surgical therapy by in 1896 with Dr. Bateson doing oophorectomy, and today we have the modern AIs coming up. So breast cancer, we always use sequential hormones, but it's important to remember that with increasing lines, there is a decremental effect of these therapies. So this was a study, the BOLERO-2, which looked at combining an mTOR inhibitor, everolimus, with exemestane to show that the outcomes were better when we targeted mTOR. The clinical benefit rate being 33.4% versus 18% in favor of everolimus. So we have been having this drug sirolimus for a very long time in our country, and it's been used by the nephrologists for a long time, and we know the toxicity profile. And it's again a very cheap mTOR inhibitor. So this was a study which was led by one of our very senior medical oncologists, Dr. G.S. Bhattacharya, which was presented as a preferred paper in ESMO 2012. And this was a study combining sirolimus with tamoxifen. And just to show you, the clinical benefit rate was 62.1% versus 14.4%. And again, sirolimus as compared to everolimus is a very, very economical drug that we have. So with that, let me talk about metronomic chemotherapy, because again, this is a very cost-effective way of treating our patients. We know that cancer cells, the effect of metronomic chemotherapy is not cytotoxic but cytostatic, and more important is that these drugs have a effect on the microenvironment and also on the T cells. So this is just to show you what a metronome is and why we have called this as the metronomic therapy. So this is the effect on the immune system. As I mentioned, the metronomic chemotherapy has effect on the Tregs and T effector cells, and this produces a good effect on taking care of the tumor. So this is just to show you the difference between how the metronomic chemotherapy is and how our conventional chemotherapy is. The same thing is listed here. The metronomic chemotherapy is low dose. Dosing frequency is continuous. Some of these drugs are used weekly, some daily, some alternate days. And this is so because it leads to a sustained plasma concentration. And as I mentioned, this also targets the endothelial cells of the vasculature of the tumor, and the toxicity is pretty less. So this is one of the papers that has been published from Tata Memorial Hospital of their experience in head and neck cancers, and they showed that this resulted in a promising progression-free survival. And this was also being done in another study from All India Institute of Medical Sciences, especially during the COVID pandemic time. And this showed that this was in fact feasible to be done with remote monitoring of the patients. So with that, let me go on to the supportive care, what we have done and what we can do. One of the things is the neutropenic fever. So the concept of prephase in non-Hodgkin's lymphoma, this was a paper that we published in European Journal of Hematology in 2018. What we did was we were seeing that if we initiated R-CHOP in many of our patients, they were having a lot of tumor lysis syndrome and coming back with neutropenic fevers. So what we did was we instituted this prephase, which was weekly vincristine and steroids. We used to give 4 to 6 weeks and then institute the actual chemotherapy with rituximab. And what came out of this was that we were able to improve the performance status of these patients. So this is, if you see the before prephase, we had PS of 3 in almost 18%, but after the prephase, we did not have anybody with PS3, and most of them, the PS improved. Also, the neutropenic fevers, the neutropenia and the neutropenic sepsis dramatically fell in the group that had prephase. So this was again a cost-effective way of trying to decrease the problems that the chemotherapy produces, and they also decrease the burden on the hospitals. So other important problem that we have is nausea and vomiting. And this was a study that we did using olanzapine. This was a study that was funded by ICON in an award paper. And this study was to look at the cost effectiveness of olanzapine versus aprepitant. Aprepitant at that point of time had just come in and it was expensive. So we thought we will try and look at this. So this was a phase 3 study, a pilot study of course, comparing aprepitant versus olanzapine. And the conclusion was that there was no significant difference between olanzapine and aprepitant in preventing nausea and emesis with highly emetogenic chemotherapy. Apart from mild drowsiness, there was no other significant side effect observed. In fact, nausea was better controlled with olanzapine. But more important, the cost of aprepitant was 3,000 rupees, whereas olanzapine was just 5 rupees. So this is now being widely used across our country, and I think it's a very good drug to control nausea, which is not being addressed very well at all. So what else have we done to tackle our issues of economy is we've been involved in putting up guidelines which are specific to our region. And this is the first of it which we published in Indian Journal of Cancer on head and neck cancers. And this has recently been updated and it will be published soon. We did the study of treatment patterns of comparative analysis of non-intensive regimes in elderly acute myeloid leukemia. And we published this in the Journal of Hematology. this was a real world experience from India, and we showed that this was feasible because we were able to decrease the morbidity and mortality in this elderly group of patients. And the important thing was the American Society of Hematology in 2020, in their guidelines, have actually quoted our paper for treating newly diagnosed acute leukemia, acute myeloid leukemia in older patients. So I think that is a nice thing for us. This is the other paper of which we were a part of. This was published in Lancet, looking at choosing wisely India, 10 low value or harmful practices that should be avoided in cancer care. And fortunately, I've been an author in this paper as well. So these are some things that we've been doing with either guidelines or consensus statements to help and address the economy issues that we have in this part of the region. So this is the other one, the PAGA guidelines, which is Pan-Asian adopted ESMO guidelines, and the ISMPO, which is the Indian Society for Medical and Pediatric Oncology, has been partnering ESMO for many of these guidelines over the last 5 years, and this is one on unresectable locally advanced non-small cell lung cancer. So we recently led this PAGA guidelines on endometrial cancer, and Dr. Amita, important contributor for this guidelines, is also here. So the other thing that we have been doing is the consensus document for various cancers across India, and this is an initiative led by Indian Council of Medical Research, and in 2014 to 2017, they have published for about 23 cancer types, and I've been chairing this for esophageal cancer. So this is an important consensus guidelines because this gives us 3 different tiers of care for our patients based on the resources, the expertise available, and the facilities that we have in each part of the world. So this is again a concept that we are talking about, real world evidence, and this is a statement made in ASCO Post in 2016, talking about engaging clinicians in collection of cancer registry data to improve clinical research. So in this regard, I must actually acknowledge Dr. Ramesh Nimagada in our country, who has started this project called OncoCollect, and for last 1 decade, he's striving hard to work on this. And this is just to show you the various centers that are involved in this OncoCollect registry, which is looking at real world data. And we have actually published about 5 papers that has come out of this collection. Just to show you one snapshot of what has come out is looking at the primaries which are identified in 3 hospitals. As you can see, this is a staggering almost 2 lakh number of patients. And as you can see here, head and neck continues to be the highest incidence of cancers, followed by lung and several others. And what's also come out of this is the trends across the period of 1996 to 2017. And this is for the females, which are almost 51,681. And as you can see, the cervical cancer has dramatically come down from 1996 to 2017, whereas breast cancer has gone up, whereas the other cancers are very similar. So this is again showing you the real world data. If as clinicians we are involved, we can actually see how the trends are and probably cost effectively try and have guidelines and recommendations for our treatment. With that, I will stop and thank you very much.